So hi everyone. It's a pleasure to introduce our product, ChatPath. So it's an AI tool that reduces diagnostic variability. This idea initially started with breast cancer. Actually, one of my really good friends during PhD was diagnosed with breast cancer at a pretty young age, and unfortunately, it was a very aggressive type as well. So, I've realized that we actually see cancer diagnosis in family and friends, but what can I do to contribute to this field? So since then, I've shifted my research area, and this has been my research focus during pretty much all my career to this day. And like I said, this project started with breast cancer, but because we've been working on it for many years, so this has expanded to many other different types of cancer as well, which I will show later in this pitch. And this product started from a patient perspective. So after a biopsy is taken from the patient, what are some of the information that the patient needs to know, right? So diagnosis, their treatment, and of course, their post-treatment outcomes. And all of these actually involves some kind of decision making. This decision-making process usually involves specialized individual or teams of individuals doing specialized tasks. The workflow for pathology, I would say, is not very well consolidated. And part of the reason is because we're working on these very complicated problems. So not surprisingly, there exists a lot of diagnostic variability between pathologists. And if I simply just split the features on the biopsy into simple and common versus complex and rare, what we'll see is that there can be up to 60% of the between pathologists variability. What that means is that if we have one biopsy from one patient and two pathologists, they may have completely different views on what this diagnosis is. And these diagnostic variabilities leads to major complications for both the patient and of course for drug development trials because their target population is actually not what they have recruited. Um, and here's the solution. So ChatPath acts as a second reader and quality control for this decision-making process. We focus on the diagnosis step of this pipeline where the subsequent decisions are actually dependent on this first crucial step. And here's the workflow. So at the time of digitization, so after a glass slide enters a digitizer and stores in a database, this is where ChatPath comes in. And it produces two things. So the first is feature annotation. So for example, how many cancers or how many other features, depending on the type of cancer we're talking about, and their corresponding location on the biopsy. So that can be visualized by the pathologist very easily. And the second is a recurrence score that returns the likelihood of a patient having cancer coming back to them within, let's say, 5 years or 10 years. And the status quo for recurrence score is currently on the market is genomic testing. So the most well-known one is Oncotype DX that utilizes a panel of 21 genes. And here I'm showing a head-to-head comparison of genomic testing versus ChatPath. So what we can see here is that the genomic testing is actually very, very expensive. It takes about 2 weeks to return the results. And it requires that the biopsy or the sample to be shipped to them. And the genomic testing actually destroys part of the sample in order to perform that extraction. And is currently only accessible in the US. Whereas if we look at ChatPath, it costs about $5, so which is 920 times cheaper. It's instantaneous, so it does not require the tissue to be shipped anywhere because it's performed at the time of digitization, which is on site. And accessibility is wider because it'll be available anywhere digital pathology is performed. And a little bit more about our technology. So we have trained the algorithm for over 10,000 patients and 11 cancer sites right now and expanding. Here's a taste of, I'm showing 6 of these sites with their corresponding sensitivity and specificity. So there's a lot of data on here, but what I would like to point out is that the sensitivity for all of these features are well over 90%. The specificity for the majority of these sites are controlled to be well over 80%. So there's a trade-off, obviously, between sensitivity and specificity. And we have conducted some interviews with clinicians or pathologists, and their view on the trade-off between the two is that they can accommodate false positives more than false negatives. So therefore, our algorithm right now is trained towards to maximize sensitivity part of it for clinical purposes. And here I'm giving an example of, so those two features in the black box there are examples of a rare and complex feature. What we can see here is that even for those, the sensitivity is well over 90%. For computation, we separately compare feature annotation and recurrence score because you can see that there's no single company out there that can perform both right now in the market. For feature annotation, we see that the competitors are pretty much segregated in some specific cancer sites of interest, whereas ChatPath can handle over 11 cancer sites. And a similar story for the recurrence score. So Oncotype DX right now only focuses on breast and colon, and others are pretty much just on breast. So, looking at these comparison tables, I think our secret sauce is not just the fact that we can do more cancer sites than the competitors. It's actually the algorithm behind it that we have trained in, but more importantly, the data behind these sources. So in terms of the market size, I had a rough estimate of the number of hospitals, clinics, research institutions, and pharma that actually performs or analyzes pathology. We can see that in the yellow circle there, the service obtainable market in just US and Canada in 2019, there are over 48,000 entities where half of the hospitals, just less than half of the clinics and pharma have the need to perform and analyze pathology images. For a business model, the revenue is on a recurrent basis. It'll be subscription, licensing, or service-based. For feature annotation, it seems more reasonable to be a subscription or licensing-based. So this depends on whether the entity owns or rents the digitizer. So for example, small rural hospitals may be renting their digitizer, and therefore it may be more reasonable for them to be on a subscription-based model, for example. And the recurrence score, on the other hand, may be in contact with the oncologist or the pathologist. So it depends on the makeup of that clinical team. And therefore, service in that case seems to be a more reasonable model. We're also currently talking to the Clear lab at Washington University. So we will be validating over 50,000 patient information stored in their database for validation and verification. So if the performance of our algorithm is well validated in that big cohort, we'll be generating a small amount of revenue and then implemented for their prospective annotation services. And throughout this process, we may be able to generate a PLA code that could lead to reimbursement. For marketing, we'll be giving talks in academic conferences about the product. We'll talk to patient advocacy groups. So for example, we have a very active group of advocates at WashU for this kind of product. Also, there's an ultra-active group of pathologists on Twitter and X that post challenging cases and looking for diagnosis for those, where we could kind of participate and promote our product there. For sales, so it will be a direct sales or partnering with the digitizers. We've already talked to some of the digitizers, so big digitizers like Philips and Leica and small companies. So the most important thing that we've learned is that the big digitizer companies currently do not have a preferred third-party annotation AI tool. And delivery is a simple on-site installation. It'll be strictly offline to protect human subject information. So let me show you what we've done in the last year and our short-term projection. So back in the Q2 2023, we have filed a provisional patent that has recently just been converted into a non-provisional patent. And this is for the algorithm. Q3 2023, we started a conversation with the FDA consulting firm, and we have recently finished drafting our pre-submission and aiming to have a pre-sub discussion with folks at the FDA early fall, so in September this year. So the FDA and the patents are supported by fundings at WashU, where we secured a 56K in 2023. So looking to the last half of 2024, we're continuing to explore the Clear lab contract. We would like to have a clear idea of our go-to-market strategy. So with that clear path for go-to-market strategy, we'll then have an absolute estimation of the funding needed. And this is our team for ChatPath. My background is in statistics and data science, and is the key behind the algorithm for the product. So Graham is a world leader in cancer epidemiology. In fact, he's one of the most cited researchers in the world. Rob is an expert in pathology and advisor on feature annotation and looks after the clinical ground. So we obviously have complementary expertise in the team. And I would like to say that we're a super productive team. So if some part of the pitch looks early to you today, I promise you it will not be in 3 months. And this is a summary of the pitch, where we aim to provide this inexpensive, fast, reliable, and accessible cancer test. This has been done over 11 cancer sites, and we're still expanding. So thanks so much for listening.